viewers, welcome again to the LifeRef Group's GIST Day of Learning Tennessee in collaboration with Vanderbilt Ingram Cancer Center. We're really excited to be gathering with you all here virtually. My name is Diana Nieves. I'm Senior Director of Outreach and Engagement at the LifeRef Group, and just a warm welcome all the way around. We want to thank our sponsors for making all of our GDOLs possible this year. Blueprint Medicines, Decipher Pharmaceuticals, Genentech, and Novartis. We're very grateful to them. Some logistics, please make sure that your mics are muted. We want to make sure that we are able to hear each of the presentations, each of our presenters here today. So please just keep them muted. If you have a question, there will be some time to answer, have a Q&A. But if you're a little shy, no worries. You can type it into the chat box and I'll make sure to ask the questions on your behalf. So let me pass over the mic to our Senior Vice President at the LifeRef Group, Laura Acuzzi.
Thank you, Diana. And thank you for all the hard work you put in to organize this event along with the members of the Medical Center at Vanderbilt. Thank you for joining us as you begin your Friday evening and moving into the weekend. We appreciate you being here, and we certainly appreciate the sarcoma team at Vanderbilt Ingram Cancer Center. I'm going to introduce Dr. Elizabeth Davis, a sarcoma specialist there, and she's got her team with her. And we're so grateful that all of you can join us today and help educate our patient community. With that, I'm going to turn it over to you, Dr. Elizabeth Davis. Thank you.
Thank you, Laura. Thanks, Diana. Hi, everyone. Thanks so much for joining us this afternoon. We're very excited to talk to you about how we treat GIST here at Vanderbilt. And so without too much further introduction, I'm going to let Dr. Prieto Granada start us off. He is from the Department of Pathology here at Vanderbilt, and he's going to talk to us a little bit about the diagnosis of GIST. Carlos?
All right. Thank you. Hello, everyone. Good afternoon. Let me just share my screen. All right. And to hit this. Do you guys see it?
Yes.
See the screen? All right. Thank you. All right. So I'm going to talk about pathology. Very briefly, the items I'm going to go over are what do we do as pathologists? I know there's like a specialty that's not, people are not very familiar with our specialty. Basically, what I tell people is when they ask me my specialty is I'm a lab doctor. So basically in the lab, we don't really see patients, especially the anatomic pathology part of things. Some people are blood bank see patients, but we don't really see patients. We see biopsy material and resection material. So then I'm going to go over the basic tumor classification or neoplasm classification of the gastrointestinal tract, some historical aspects of GIST and how we diagnose GISTs, and then very briefly, because I know this is going to be discussed further on, risk stratification based on pathologic features, and then very briefly also molecular aberrations or in GISTs. So what do we do in pathology? Basically, what we do here is, so we got our specimens from the OR. Any surgery that's done produces a specimen that is transported to the lab where it's sectioned. So there are people cutting the specimen, submitting pieces of it, like that are very important, say the margins, meaning the areas where the specimens was attached to the rest of the, say, the small.
Did you say that again? I'm having trouble.
Siri. So, margins and tumor sections. So those we put in this processing that results in glass slides that we can look under the scope. So it's a very cumbersome process and a very old process, more than 100 years old. that basically produces these paraffin or wax blocks with the pieces of tissue. So these pieces of tissue are the tumor or the parts that we sample. And this goes to a file, and these blocks get cut very thinly and stained so we can examine and tell the surgeon or the oncologist, oh, this is a GIST, or this is a squamous cell carcinoma, or this is an adenocarcinoma. And we tell them, oh, this is invading to this level of the, small bowel, or, the stomach. So all these, factors that they use to stratify and stage tumors. And that's just only one part. So we also take care of like non-neoplastic things, meaning inflammatory processes, all that stuff. But in terms of what we do as pathologists, that's kind of like the core. So I wanted to put that out so people understand how these images are produced. So basically, when we get a GI tract specimen, we usually section them because they're tubes, basically, right? We section them across, so there are cross sections most of the time. So if you examine, so this is a cross section of a small bowel or small intestine. And if we examine these at higher magnification, so we can change that in the microscope, we see that the GI tract in general is composed of many layers. So this will be the inside of the gut, and this will be the outside. So the inside is lined by epithelium. Then we have something called submucosa, and then we have the muscle, because these have to contract to, to aid, because of the process of digestion, you have to advance this bolus of food, throughout the tract or throughout the tube. So we have two layers of muscle, and in between these layers of muscle, there's nerve tissue. So nerve tissue is what stimulates this muscle to make this move and to make the food advance throughout the tube, right? The GI tract or the intestine. So all these layers will give rise or will harbor tumors. So something goes wrong, and then a tumor is produced. So there are benign and malignant tumors. So benign tumors of the epithelium or the inner portion of the gut are called adenomas, and malignant ones are called adenocarcinomas. But there are also, these are by far the most frequent tumors found in the GI tract, but there's also very rare tumors that arise or differentiate towards mesenchymal elements in the wall of the tube or the gut, right? So there's smooth muscle tumors, and there's neural tumors, and then there's GISTs. So for a long time, we didn't understand what GISTs were. People were wondering, or these are muscle derived or differentiate toward muscle, or these are neural. So these lesions differentiate or differentiate towards a particular cell called the interstitial cell of Cajal. So these particular cells were described by this gentleman over here, more than 100 years ago, from Spain. So he studied neurons. So if you Google him, you will find all these drawings that he made of the images he was looking at under the microscope. Beautiful drawings. I mean, they're like works of art. So what are these cells? So these cells that they were described by him, in 1894. These cells are actually the interface in between the neural tissue you find in between these muscle layers, which are these that he already drew back then, and the muscle. So basically, they're interfacing the cables, if you will, to the actual motor or the contract, something that will contract and produce this movement. Now, this is automatically produced, so is fed by the autonomic nervous system, which is automatic, so we don't really know this is happening. So these are very characteristic cells that express this marker over here, which is called KIT or CD117. So for a long time, these cells were practically ignored. We didn't know what they did. But then at the beginning of the 90s or the end of the 90s, so this paper is mid-90s, 95, they discover in mice that these cells were in charge of they were basically pacemakers of the gut. So basically here are two graphics showing the normal electric activity of the gut of these mice, and then these are the mice that have the mutation or they have an abnormal KIT or CD117. So the normal one, you can see here that is very regular, and then here the mutant is very erratic. So all these little spikes are very erratic in contrast to this. This is electrical activity, and then if you block them here with a drug, they're completely effaced or they're silent, and these guys are completely normal. So they found that these cells, interstitial cell of Cajal, are actually the pacemakers. So very important in the normal gut development, but they can originate, or tumors can differentiate towards this particular cell phenotype or class, right? So that's what GISTs are. So basically GISTs, the majority of them will arise in that part of the gut, meaning the part that is not the epithelium. So we see here the epithelium, the mesenchymal part, so the wall, the thick wall, right? More often than not, they're they have these very elongated cells. They're also epitheliate forms, meaning their cells are a little plumper. And the great majority of them will express this marker, meaning we have some tests that we can perform on those sections that will highlight this particular protein in the tumor, which is the 117, CD117, which is also expressed in the norm. This will be the normal area here of the gut. So that means that, these cells, even the normal cells will express this marker. So basically, that's how we diagnose GIST. So basically, we put it on in the we section the specimen, the gross specimen here, and this is the microscopic. We look at it on the microscope, and important things that we need to look for are, both size, meaning here in the large specimen or the microscopic view, we measure the size of the tumor right here. And then one of the microscopic important prognostic factors is the mitosis, meaning mitosis are the way the cells replicate. So basically we count how many mitoses we have in 5 millimeters squared, which is a number of sites fields we look at. So basically we divided, if the tumor has less than or equal than 5 or more than 5, and then also the size of the tumor. So these are cutoffs. If it's equal or less than 2 centimeters, 2 to 5, and then 5 to 10 centimeters and more than 10. So that's how we assign risk for the tumor to behave badly. The bigger the tumor and the more mitosis, the higher the risk. And also we have to take in consideration if the lesions are arising from the small intestine or the stomach. So we use this table to kind of convey that information to the oncologist. But it also, the presence of metastasis at diagnosis, of course, is very important. So this is a graphic that my colleague, Justin Cates, gave me of a study they perform on a very large amount of cases, almost 20,000 cases. And this is comparing the people that have metastasis, meaning the tumor has spread elsewhere, more often than not is the liver, versus the one that did not have metastasis. So this is the time from diagnosis, then years, and this is the survival. So this means that over here, we have 50% of these people that started here, we have only 50% of them are alive in this black line, which is the line that indicates metastasis, versus this blue line indicates no metastasis. So, you know, in that same cutoff point, 80% of the people are alive. And these are comparing to these lines over here, which are healthy match people from a database. So metastasis, the presence or absence of metastasis is also very important for prognosis. Now, there are very characteristic molecular aberrations that affect GISTs, which almost the great majority of them involve this KIT or CD117 gene, the gene that codes for the protein. So the protein is basically a tyrosine kinase. So tyrosine kinase are proteins that can be blocked because they use another molecule to produce the signal that is required for the tumor to proliferate. So if we block that that site of the protein, then we can kind of inhibit growth and proliferation of the tumor. So that's the basis for Gleevec, which is in Imatinib. And then over time, there were other aberrations that were found in GIST, including succinate dehydrogenase deficiency and some other rare aberrations. All right. So basically, I think I'm good on time. GISTs are rare mesenchymal tumors arising from the wall of the GI tract, not necessarily the epithelial portion, and they derive and then differentiate towards the interstitial cells of Cajal, which are usually the bowel pacemakers. Then what we use for prognostication is tumor size, mitotic activity in the presence or absence of metastasis. In the great majority of the GISTs, 75, that should be 70, oh yeah, 85% putting together KIT and PDGFR-A, which is the other mutation that responds to Gleevec. The great majority of them will respond to Gleevec since they harbor these activating mutations. And with that, any questions? Sorry, it's kind of technical. Questions? No?
So question, if I may ask?
Of course.
Yeah, first of all, thank you very much. It was very informative. So my question is, and I apologize if I'm not writing using the right words.
Oh, no problem, no problem.
For the pacemakers that they exist in the gut.
Yes, sir.
If you observe a tumor in it, also can it come with any other disease for that they get that the function of it becomes different, or the only effect of tumor is
right? This is a very good question. So these are non-functional. These tumors don't produce any motility. I mean, if they produce a problem in the gut, it will be because they're big and they occasionally might obstruct the gut, but usually these tumors grow on the outside of the gut, like in here, this picture over here. The tumor is growing from the outside because they take origin from this portion of the but this portion of the gut. The only problem that they could potentially produce if they grow inside over here might be obstruction, but these are non-functional tumors though. So
but I think that's exactly my question, because if you look at the pictures that you are doing, the parts that you are saying mesenchymal tumor, so these are the function of these elements is to push food through the intestines, right?
In the normal gut.
Yes, in a normal gut. Right. So if one grows a tumor in there, that's the function of these changes?
No. All the other guys are fine. The other interstitial cells of Cajal are fine. They don't get involved, they don't get affected by the tumor. And the tumor itself, the tumor themselves are not, they don't produce any effect, in the motility of the gut. They're not, interfering with any motility, any movement of the gut. So what they produce is metastases if they're high risk. So more like a cancer, not necessarily problems in motility. I don't know if I can, if I'm answering your question.
Yeah, I think you made it clear. Yes, thank you.
Okay, no problem.
Yeah, so I have a question.
Yeah.
You had mentioned that the tumors on small intestines tend to be higher risk for spreading than the ones elsewhere, like on the stomach. Do you know why that is by any chance?
Well, one can speculate that maybe the small intestine has like a thinner, so the stomach tends to have a thicker wall versus the small intestine. It might be because of that, but there's no really studies that address that in detail because it's difficult to kind of prove either way. But it's not that they're high risk, but if you look here, the small intestine over here, most of them are high risk here in this table, right?
Mhm.
But see here, for example, this one that more than 10 centimeters in the stomach will be moderate, but in the small intestine will be high, right? I suspect, but there's no way for me to prove that is because of the wall being in the small intestine being thinner, way thinner than the stomach.
And I think there are also some differences in the mutations and that I'll talk about too, and that
Could be, yeah.
as far as the stomach, the mutations that occur in the stomach are often some of the lower risk GISTs, and the mutations that occur in the small intestine tend to be the higher risk GIST. We don't know, or I'm not aware of why that may happen, but
Right.
there are differences in that as well.
Okay,
That's a good
thank you.
point, yeah.
I have
Right,
a question.
Oh, sorry. Didn't mean to cut someone off.
I have a question. My wife's GIST was, I think, called wild type because it was in her abdomen. And your table has small intestine and stomach. It was in fact wrapped around her intestines. They had to do 3 resections, 2 in the small intestine and 1 in the large intestine. How does that affect your analysis of the risk?
Well, these are the most common sites, but of course, there are GISTs that can show up in the esophagus, large intestine. So in those cases, we basically look for mitosis and also give the size. And regarding risk assessment, I don't think I think I have some other papers showing large, the different, I didn't put the table because it's going to be a lot of, numbers. And see here, for example, there's this table over, I don't know if you can see it. So there's very complicated table here, for example, showing the rectal GISTs, duodenal GISTs, and all these, the mitosis and the sizes. So we do have, parameters for other sites, but I just put the more frequent sites in that table just to make it a little simpler.
Thanks, Carlos. I appreciate it. I think it was a great talk, very informative, and lots of
Thank
good
you.
discussion as a result of it. I think in the interest of time, we may close questions for Dr. Prieto-Granata right now, but at the end, maybe we'll have some time if people have some more thoughts for him. So our next speaker today is going to be Dr. Deepa Mcgee, who's a surgical oncologist here at Vanderbilt, and she's going to talk about the surgical management of GIST. Deepa?
Thanks for having me. I'm happy to present some slides. So let me just share my screen. Maybe. There we go. Can you see that? Hopefully.
Yes.
Okay,
Yeah.
perfect. Perfect. So as Dr. Davis said, I'm one of the GI surgical oncologists here at Vanderbilt, and I joined the team about 2 years ago. I moved from New York and came over here and have been extremely, extremely happy. And Dr. Davis and Dr. Kitty and I work together a lot on joint patients. So I'm happy to answer any questions at the end of the presentation. So feel free to accumulate some questions for me. So I have nothing to disclose. So my presentation today, and I hope nobody's squeamish because I do have some surgical pictures, and I forget sometimes that not everybody comes to the operating room. So hopefully nobody's too squeamish. But today's talk, I'm going to speak a little bit about the background of GIST. I'll talk about the surgical management of primarily gastric GISTs, as well as small bowel GISTs. I'll talk a little bit about what to expect post-operatively. I'll give you a typical case presentation of patients that come to see me. I'll talk a little bit about surveillance, and then I'll be happy to answer some questions after that.
Hey, Deepa, I think you might want to make your slide full screen. I think it's in presenter mode right now.
How do I get out of that? Hold on.
I think it's the far right one.
Right. It's not letting me change it. Hold on, let me see something. Is that better?
That's perfect.
Okay. So GISTs are the most common mesenchymal tumors of the GI tract. They can occur along the entire GI tract. So we see GISTs of the esophagus, we see GISTs of the stomach leading to the small intestine, as well as to the colon and the rectum. As Dr. Carlos said earlier, they result mostly from KIT mutations or PDGFRA activating mutations. The annual incidence in the US is about 0.78 per 100,000. And as I mentioned, they can really arise anywhere along the GI tract, but the most common location is within the stomach. The second most common is within the small intestine. The other locations that we see relatively commonly, because we are a GI center for uncommon malignancies, is along the duodenum, around the esophagus, as well as in the rectum. So in terms of management of GISTs and surgical management of GISTs, the typical operation consists of trying to do a resection of the GIST and the wall of the structure that it's involving. Because it typically does not involve the lymph nodes in the local regional area, unlike other cancers like the traditional colon cancer or small bowel adenocarcinomas, we don't have to do a lymphadenectomy. So when we do these surgeries, we primarily try to do a wedge resection of the structure involved. And if it's not possible to do a wedge resection, then we'll do a resection of the small intestine or the colon and put things back together. The goal of the surgical intervention is really to achieve negative margins, so resecting the mass on block with the involved structure, and achieving negative margins, meaning there's no cancer cells left behind when we remove it. GISTs tend to be very fragile. They have a pseudocapsule around them. So intraoperatively, we try to be extremely gentle with them. So we don't want to rupture them intraoperatively, because if there is rupture or injury to the GIST and there's spillage of tumor cells, patients can have recurrence relatively early, and they can present with other abdominal metastases from it. So we try to be very methodical in our surgical resection and try to maintain the capsule of the GIST as much as possible. In certain situations, unfortunately, especially in the very large GISTs that involve multiple structures, sometimes rupture is unavoidable, but we try our very best to prevent that from happening. So for the most part, especially for gastric GISTs, we are able to do wedge resections, meaning we take the mass along with a portion of the wall of the stomach. However, in comparison to the stomach, the small intestine has a much narrower caliber lumen than the stomach. The stomach is like a balloon, so you can resect a portion of it and patients do quite well. Whereas with the small intestine, we can't resect a portion of the small intestinal wall without narrowing the lumen of the wall or the inside of the small bowel, resulting in a bowel obstruction. So if it's involving a small intestinal segment, we typically resect the segment and put things back together. So I think Dr. Kitty or Dr. Davis is going to speak a bit about neoadjuvant therapy for GISTs. Typically, when GISTs are of a size that is relatively reasonable and the resection won't cause significant morbidity or complications for the patient, or doesn't require a multivisceral resection, meaning we don't have to resect other organs in addition to the segmental resection, we prefer to do an upfront surgical resection. However, in the case where we have an extremely large tumor that's involving adjacent structures, and I think Dr. Kitty is going to talk about exon mutations, for patients that are responders to Gleevec, we do try to do a neoadjuvant therapy approach first to try to shrink the tumor to decrease the extent of the operation that we have to essentially do. So this is our NCCN guidelines. It's relatively straightforward, but it kind of maps out exactly what patients we take directly to the operating room and what patients we prefer to do some sort of neoadjuvant or pre-operative therapy. So for really small GISTs, and these are less than 2 centimeters, we use 2 centimeters as our cutoff for sizable GIST. If the size of the gastric, and I'm focusing primarily on gastric because these are the most common tumors that we see. For very small gastric GISTs that are less than 2 centimeters and they have no high-risk features on imaging, you can consider endoscopic surveillance and you don't need to proceed with a surgical resection. However, if there's any high-risk features or it's larger, so we're getting above 2 centimeters, then we do prefer to do a complete surgical resection. Now, this goes down into if the tumor is resectable with minimal morbidity, meaning that the operation is not going to be extremely extensive and the risk of a complication is really low, then we'll proceed with a complete surgical resection. If we're worried about about complications arising from the surgery, then we consider giving neoadjuvant or preoperative therapy to try to shrink the tumor so we don't have to do as extensive a surgery. So the typical gastric GIST location, this is a picture of the stomach. This is the esophagus draining into the stomach, and this is where the stomach drains into the duodenum. The most common locations for these tumors tend to be on what we call the greater curve of the stomach, which is the best location for tumors for us because it makes the resection quite easy in order to be able to do a wedge resection. So essentially, when I talk about a wedge, it's exactly that. So if a tumor, a GIST tumor is extending from the greater curve of the stomach, instead of extending into the stomach, typically extends outside. So it's almost like this extrinsic mass. So what we do is we essentially do a wedge resection of the stomach along with the mass. Other locations for these tumors are along the lesser curve of the stomach, which makes it a little bit more challenging to do. The toughest location is along the esophagus or at the GE junction because we can't do a wedge resection of this location because it could narrow the caliber of the esophagus, making eating and drinking impossible. So if it does involve the GE junction or it does involve the esophagus, we do recommend some preoperative therapy if they are candidates for that to try to shrink it. But in order to maybe do a wedge resection, but sometimes that's not possible and an esophagectomy or gastrectomy is required. So for resectable GISTs that are locally advanced, meaning involving adjacent structures, and the most common structures that are involved are the distal pancreas, the spleen. Let me see if I have that picture of the GI tract. So here's your stomach. The spleen sits right here, right next to the stomach. And the pancreas actually sits right behind the stomach. I don't know if you can see that structure right here, but the pancreas sits right there and the spleen sits right here. And this transverse colon, or part of the colon, sits in very close proximity to the stomach as well. So the most common structures that we see involved in large GIST tend to be the spleen, the pancreas, and the transverse colon. So when we see these large GISTs involving these multiple structures, because the morbidity of doing a pancreas resection is pretty high, that's kind of the worst part of a surgeon's job, is dealing with the pancreas, to be perfectly honest. If it is involving those structures, we do tend to give some neoadjuvant therapy up front. So this is a picture of a laparoscopic wedge resection of the stomach. So there's several ways we do surgical intervention for GISTs. So we can do it in a laparoscopic or robotic technique using minimally invasive techniques. This is with small incisions. So up here is where we place our small ports. And then we have to make one of those port sites a little bit larger in order to remove our specimen. So this is the robotic technique. This is the laparoscopic technique. And then this is the traditional open technique, which we use for larger tumors or tumors that are involving multiple structures. But this is just a quick picture of actually one of the cases I've done. This is a large GIST that's extending from the greater curve of the stomach. And as you can see here, you can actually see a pedicle of the GIST extending from the wall of the stomach. And so what we do is we staple across the stomach at the base of the GIST, and then we send it to our pathologist to confirm that our margins are negative intraoperatively. And if they say, hey, we see some cells or cancer cells at the staple line, you might want to take a little bit more. We'll take a little bit more with our stapler intraoperatively. And if we feel we're worried about narrowing the lumen or the inside of the stomach at all, we'll perform an EGD to confirm that we're not narrowing it when we do our stapling. So I'm just going to talk about small bowel GIST just a little bit because they are rarer. And like I mentioned before, these typically do require an actual resection of the small intestine segment involving the GIST, because of the narrower caliber of the small bowel lumen or the inside of the lumen. So we can't do a wedge resection of the small intestine. So for this, we also can offer laparoscopic, robotic, and open techniques. So the most common way we do small intestine GIST is in a fashion called a laparoscopic assisted or hand assisted operation, which is essentially where we use a hand port and we feel for where the tumor is intraoperatively, and then we pull out that segment outside of the abdomen, and we do the resection that way. That way we're able to maintain the size of the incision to about that big. So it's a relatively straightforward way to do that. So what patients are candidates for GIST surgery? I think, if we can do a complete resection with negative margins, they quote that we can cure, I say in quotes, about 70% of patients with surgery alone. But, 30% of patients will develop a recurrence, and that's when the tumor recurs. Your care team, when you see, the surgeon, the medical oncologist, will kind of decide whether you're a candidate for surgery based on your performance status. So if you are fit for an operation, because general anesthesia has a lot of risks, and obviously there's a lot of operative risks. So we base these decisions on other medical issues, your performance status and frailty, your nutritional status. All of these things play into whether we can perform an adequate operation for you. So we want to make sure that you're in adequate health in order to undergo a surgical intervention. And the biggest thing that we say is that, patients always ask, is this a good tumor to have? Obviously no tumors are good tumors, but GISTs, especially of the stomach, when they're located on the greater curve of the stomach, can be extremely responsive to surgical intervention, and patients do very, very well with surgery. So what to expect post surgery if you do undergo a resection for a GIST? If you undergo a partial gastrectomy or a wedge gastrectomy, most patients return to their quality of life or their baseline quality of life within a few weeks of surgery. If you have to undergo a small bowel resection or a colon resection, I typically say that patients require a few months to really get back to baseline bowel habits. So you can have some erratic bowel movements for a few months, and then it gets back to baseline after a few months. Generally, immediately post-operatively, you're in the hospital for about 3 to 7 days, but it really depends on the extent of the surgery. So if we do have to do a resection of multiple adjacent structures, then patients are in the hospital longer than for those that we have to just do a wedge gastrectomy. We expect patients to be sitting and walking on day 1. Most patients are able to eat on day 1 as well. So we try to get patients ambulating and moving as quickly as possible. And like I mentioned, every patient is different in terms of their recovery. Some take a few weeks to get back to baseline, but some patients take a little bit longer and require a few months to get back to quality of life. So I just wanted to present just a typical case presentation of a patient that I see in clinic. So we have a 54-year-old male who comes into the clinic with complaints of mild pain in the epigastric region, which is in the upper abdomen. Complains of having trouble getting full really fast, doesn't complain of any nausea or vomiting, no bleeding, no vomiting blood or any blood in the stools. He goes to his primary care physician who gets a CT scan. And so this is a typical CAT scan of a patient that can come and see us. So just briefly, this is the liver, this is the stomach, and this is the spleen. And there's this abnormality extending from the wall of the stomach. And this is a really good view of, you can see a stalk of this tumor that's extending from the wall of the stomach. You don't see it extending into the stomach, it's extending outside. So this is very consistent with a traditional GIST of the stomach. So in terms of how we manage that type of patient, we would recommend an EGD to assess whether there is any compromise of the inner lining of the stomach, also to get a biopsy of the mass. And an EUS is the endoscopic ultrasound, which is a typical endoscopy that has an ultrasound probe at the end of it. And it can determine some characteristics of the mass that's helpful for us. And then we get a biopsy, and typically it comes back as a gastrointestinal stromal tumor, and it gives us some characteristics of the tumor, like our pathologist had just mentioned, with the c-KIT positive and different mutations. So for that patient, because that tumor was not involving any local structures and it seemed to be extending directly from the wall of the stomach, we would recommend an upfront surgical resection for that patient. And we could do it laparoscopically in most cases. And in some cases, if the surgeon is unable to do it laparoscopically, they would do a small incision at the top of the abdomen in an open fashion. So that same patient, this is a different CAT scan that we can see. So this is a large GIST. This is actually the tail of the pancreas, and this is the spleen. And if you can see, this is the liver over here, and it's kind of pushed over. And this is actually the edge of the stomach. And you can see this mass extending from the wall of the stomach, but it seems to be at least abutting, or maybe not just touching, but maybe involving the tail of the pancreas as well as the spleen. So for this patient, we would do the same workup. We do an EGD, do an EUS, get a biopsy, and look for specific mutations to see if they would be a candidate for preoperative therapy in order to shrink this so it can come away from the pancreas, so we could avoid a distal pancreatectomy. Oftentimes, we are unfortunately left with having to do the distal pancreas if it's involved from the get-go. But if we can decrease the chances of it by any means, we try our best to do so. So just like I mentioned, we would give the neoadjuvant Gleevec for several months. We'd re-scan the patient every 3 months to determine response. And there's no great data, but we kind of keep it going until the response wanes or they show stability of disease on subsequent scans, and then we would take them to the operating room for definitive resection. So I think we've already gone over this, the risk stratification of primary GIST, so I'm not going to go through this again. But just as was mentioned before, the biggest things that are important in risk of potential metastatic disease in the future or recurrence are related to a few things: the size, the location, and the mitotic index, which is really how rapidly the cells are dividing. So these are kind of the 3 important features in GIST that determine how aggressive a tumor is. And this is the same diagram actually that was used previously, so we're all consistent. And then a little bit about the use of adjuvant therapy after a resection. There's been multiple trials that have looked at the efficacy of Gleevec following surgery. And most of the studies have been looking at Gleevec in moderate to high risk tumors and have shown a definite survival benefit for patients having adjuvant Gleevec. And the latest is for 3 years. Although there is some data that one of the surgeons from MSK, who's now at Penn, is looking into kind of indefinite adjuvant Gleevec for patients with GISTs that are high risk, but typically recommend 3 years of adjuvant Gleevec after surgical resection. But obviously everything comes with risks, so all therapies come with risks, so you have to weigh the risks versus the benefit. And surveillance, just real quickly, we do CTs every 3 to 6 months, and for the first couple years, and then we do it annually thereafter. We do less frequent surveillance for lower risk tumors, and then more frequent surveillance for higher risk tumors. And that's all I have.
Wonderful. Thank you so much, Deepa. That was great. I think it's probably in the interest of time, we're going to hold any questions for now. We're going to move on to Dr. Kitty, just because I think we got to make up a little bit of time. So I'd like to introduce Dr. Vikki Kitty. She is my partner in medical oncology here at Vanderbilt. And so I will turn it over to her. Vikki.
Hi, everybody. Sorry, there's a helicopter outside my office window, but hopefully not too loud. All right, can you see my full screen? Perfect. Yes. Okay, so again, would love to thank LifeRaft Group for helping bring this to our patients. It's great to see our wonderful team and how we work together, and we really love sharing sort of the knowledge that we have and the research that is going on with our patients. And so I am a medical oncologist, specialized in sarcoma, and with just being the most common sarcoma, we're talking to you today. So I'm specifically discussing a lot of the mutations and genomics that have been sort of scattered throughout the other presentations, as well as the role of Imatinib in GIST. That is my disclosure. So I actually really like to talk about GIST. I think it's a fantastic drug development story. And I think patients with GIST who went on the initial studies are really the people who led to all this wonderful precision in personalized medicine. And so GIST is actually a relatively new diagnosis in the grand scheme of cancer diagnoses. Prior to the 90s, it really wasn't identified as a single entity. And it was called all kinds of different things depending on what it looked like under the microscope. And it wasn't really until the 70s or 80s where it was really identified as a single entity. And around that time, that's where c-Kit, this receptor that we keep mentioning, was really identified. The interstitial cells of Cajal were found to have c-Kit positivity, and that really led to the link of those ICC cells being the potential progenitor cells for GIST, and the term GIST was really coined in the late 80s or early 90s. So again, relatively new disease. And so we keep talking about KIT. So what is KIT? So KIT and PDGFR are related to each other. They are receptor tyrosine kinases, or tyrosine kinase receptors that are in the cell wall. They have a normal function in our normal cells. And we've already talked about the role in the GI tract for KIT. And what happens is that it actually takes two of these receptors to bind together to each other to activate or turn the signal on. And in a normal KIT protein, that requires a ligand called stem cell factor. And when that happens, then this act called phosphorylation happens, and then signaling happens downstream, which leads to cellular proliferation or growth of cells and other cellular mechanisms. What happens when KIT is mutated or PDGFR is mutated is it no longer needs that ligand. This signaling can happen automatically and is always turned on, and we call that constitutive activation. And the role of Imatinib is actually to block that signal. So it was really sort of fortuitous that all of this work was happening in the 90s. So we're identifying KIT, we're identifying the action of KIT, and then genetics and sequencing and all that started to happen because of the Human Genome Project in the 90s, and they started finding these activating mutations in c-KIT. And it just so happened that in another disease called chronic myelogenous leukemia, where another mutation happens, there are drugs being developed to try to block these tyrosine kinases that were being identified in cancer. And so Imatinib was actually identified in what's called a high throughput screen. And in the late 90s is when the first report in preclinical models that Imatinib may have activity at KIT. And interestingly, PDGFR mutations weren't identified for another 8 years. So a pretty big gap for that. So this is a closer look at what a KIT and PDGFR look like. So this is the cell membrane right here. So there's an extracellular component and an intracellular component. And these mutations can happen in really any of these components. As the activating mutation to form a GIST, primarily what we see are exon 9 and exon 11 in the KIT gene, and then exon 12 and exon 18 in the PDGFR gene. But if you add up these percentages, what you're going to see is that there's still about 20% that don't have a mutation in one of these genes. So again, around the 90s when there was really a lot of interest in these tyrosine kinases or tyrosine kinase inhibitors, a phase 1/2 study was started in GIST that was comparing two different, actually let me back up, because it's actually the first case report of a patient responding to GIST happened in 2000. So a patient who was able to get access to this drug prior to any of the data going on and had a miraculous response, which then led to the phase 1/2 study. So that study compared two dosing schedules. It was randomized to 400 milligrams versus 600 milligrams. And that study actually led to the approval of Imatinib for patients with metastatic GIST around 2002. And so these are the data for that trial. Again, all patients received Imatinib. So you're looking at the combined group. Patients received both 400 and 600. And what this curve is showing is how long patients survived on Imatinib. With the patients with the yellow and the blue lines are the patients who had a response to treatment. So if their tumors shrunk, patients clearly lived a lot longer. And you can see response rates of 67%. And actually this study was stopped early because the response rate was so high and the efficacy was so high that it was determined that all patients needed access to this drug and led to its approval. So the side effects of Imatinib, really overall, Imatinib is probably one of our better tolerated oral drugs. Now, for patients who have had Imatinib, you may not agree with that. But the primary side effects that we see are really tiredness, edema, which is swelling. So swelling in the legs and swelling underneath the eyes. We have to monitor the liver enzymes and sometimes have to hold or stop this drug because of liver enzyme elevations, and usually some mild nausea. And then the side effects in the smaller font are the less common side effects, although muscle cramping is, I find to be relatively frequent and a frustrating toxicity. So again, if you notice, there are 30% of patients that didn't have a really robust response. And so they went back and looked at those patients and found that there are differences amongst those patients. So if we look specifically at KIT, this was one of the initial evaluations, if you had a mutation or if the GIST had a mutation in exon 11, you had a much higher complete response rate and partial response rate than patients who had an exon 9. And then if the GIST did not have a mutation in either of those, the response rate was lower. Now, just keep in mind, the response rate was not 0. So some patients can still have response even if they don't have a KIT mutation. And this is just further analysis to kind of show what this difference is, and that this is a second study that looked at 400 milligrams versus 800 milligrams of imatinib and showed that patients with exon 9 mutations in their GIST may do a little bit better with the higher dose of imatinib. So that mutation changes the receptor to the point where you actually need a higher dose of imatinib. Or may need a higher dose. And my general approach is actually to start at 400 milligrams and increase if needed to 800 milligrams, just because if you get a response at 400, I may save you some side effects of 800. But there are definitely differences in practice patterns for patients who have a GIST with an exon 9 mutation. And then again, as I showed, there's about 15 to 20% of GIST that have neither a KIT or a PDGFR mutation. And we're actually whittling that percentage down. We have found about 98 to 99% of GIST will have an identifiable mutation on further sequencing. And so, although still rare, the more common ones that we can find are mutations in neurofibromatosis 1 or NF1. There is a syndrome called neurofibromatosis, and those patients do have risks for GIST. You can also get mutations in BRAF. These are exceedingly rare up in this corner. But then there's also something called succinyl dehydrogenase that exists in our mitochondria. So sort of the energy factories of our cells. And there are a couple of syndromes that can occur that show a loss of SDH function. And just really briefly, there are hereditary syndromes in which GIST can be associated. There are a few family groupings that have what are called germline mutations, or mutations that exist in the normal cells in KIT and PDGFR, but it's exceedingly rare. I already mentioned neurofibromatosis, and then these are the syndromes that can occur in people who have SDH deficiency. And these are just the features of the overall syndromes. And there are questions about the function of the interstitial cells of Cajal in the GI tract. And what's interesting is if you have a germline mutation in KIT, your GI tract does not function properly, so people can have kind of dysmotility issues. So from there, I feel like I lost a slide somewhere. So from there, the natural progression is to see, can we help cure GIST? So the early studies were in metastatic disease, and then now can we help increase the chance of cure? And so the very first study was published in 2009 that looked at 1 year of imatinib versus placebo. And this was early on in the GIST story, so it only required GIST greater than 3 centimeters. And there was no information on mitotic count at that point. So keep that in mind when you think about the risk categories classifications that have been shown to you. And this is a curve that is looking at recurrence-free survival. So are we delaying the time to recurrence of someone's GIST. And the top line are patients who received the imatinib for 1 year. The bottom line are patients who received the placebo, and there was clearly a difference. Interestingly, if you look at overall survival, patients in both groups did the same. And that's because at that time, imatinib was already approved if you had developed a recurrent GIST. And so you could start your imatinib and it worked so well that patients could live just as long. The other interesting part, so this is 1 year. So this is when people come off their imatinib. You can see very few patients actually had their GIST come back on imatinib, but then you start to see recurrences about a year to 2 years later. So that led to the 3-year clinical trial. And this study did show that for patients with high risk GIST, 3 years of imatinib was better than 1 year. And so this study used what's called the modified NIH consensus criteria to determine risk. If the GIST is greater than 10 centimeters, if the mitotic count is greater than 10, or if both of those are greater than 5, or if they're tumor rupture, that's considered a high risk. And those patients were randomized to 3 years plus 1 year, or versus 1 year. And you can see again in recurrence-free survival, or delaying recurrence of a GIST, 3 years was far superior to 1 year. But there was also an improvement in overall survival in this clinical trial. And so that led to the approval of 3 years of imatinib. So basically the approach is we see that patient, we identify what their risk category is, and then discuss with them the risks and benefit of adjuvant imatinib. I've got pictures over my slides. So as I mentioned, there are other types of mutations that can occur. And the question is, what do we do in that situation? So if let's say you've had a 10 centimeter GIST removed and it is negative for KIT and negative for PDGFR, then we would send additional testing on that tumor. But because not all GISTs have mutations that are sensitive to imatinib, mutation testing should be done prior to that discussion. So one common scenario we see is this specific mutation that can occur in the PDGFR gene, and that's in this, it's called D842V. It's a substitution that occurs, and this is completely resistant to imatinib. So if your tumor had a PDGFR, this PDGFR D842V mutation, we probably would not recommend adjuvant imatinib even if your tumor was 10 centimeters. Now it gets a little trickier for the other ones because we really have no data whatsoever. We don't know if there's benefit or lack of benefit for SDH, for BRAF, for NF. Typically my approach is so some of these do tend to behave a little bit more indolently. So the risk of it coming back is lower, or could be years later. But if someone has a high risk, just particularly if it's by mitotic counts, then I will have a discussion about whether to do adjuvant imatinib. So Dr. Mcgee talked about neoadjuvant therapy, which means treatment prior to imatinib. And basically my approach is if Dr. Mcgee tells me she wants me to give imatinib prior to surgery, that's when I do it. Again, just like she said, we're trying to basically decrease the risks of a particular surgery. The other place where this works, if for some reason someone is not suitable for surgery by the criteria that Dr. Mcgee discussed, then we can do imatinib often as a temporizing measure until someone can be healthy enough to undergo that surgery. So this is our timeline. And again, the reason I think it's just so exciting is if you think about the target was identified here in the very late 90s. And our first approval was in 2002. And so at that time, that was the fastest drug approval ever. And it really has paved the way for this model and other cancers. And that is everything I have. Thank you.
Thanks, Vikki. I appreciate it. I think it was absolutely wonderful. I think I may talk and then maybe we'll take a collection of questions because it seems like the chat is starting to have a few that aren't just for us, but also for the previous colleagues. So I will share my slides. So my name is Libby Davis. I am also a medical oncologist here at Vanderbilt. And I work with Vikki, and if I'm lucky, I'll be able to share my screen. Let's see. Okay, did it end up in full screen mode?
Yes, it's great.
Okay, wonderful. Thank you. Okay, so I'm going to talk about therapy beyond imatinib, current and future strategies. These are my disclosures. So I'm going to discuss the approved systemic agents for GIST beyond imatinib, talk a little bit about drug resistance, and then highlight some ongoing clinical trials. So I think it's important in order to understand the evolution of GIST treatment, I think we need to understand the timeline for approvals in sarcoma as a whole. So I promised I did not discuss this with Vikki, but apparently we both really like timelines. So mine looks a little different though. In 1974, so 48 years ago, doxorubicin was approved for metastatic soft tissue sarcoma. And it was more than 25 years later before we got another drug in the world of sarcoma, and that drug was imatinib for GIST. 5 years later, imatinib picked up another label for a disease called DFSP, and GIST got a second drug, sunitinib. Then 6 years later, we had pazopanib for non-liposarcoma soft tissue sarcomas. 2013, another drug for GIST, regorafenib. And then in 2015, trabectedin for L-type sarcomas. In 2016, we had eribulin approved for liposarcoma. And in 2019, pexidartinib for TGCT. 2020 was a big year with 3 approvals, tazemetostat for epithelioid sarcoma, and 2 more drugs for GIST, ripretinib and Abaprinib. And then just last year, nab-sirolimus was approved for PEComa. So if we look at that between 1974 and 2001, there was a kind of a big lull, but in the last 22 years, things have really picked up for the sarcoma field, and in particular for the GIST field, with almost half of our approvals in the last 2 decades in GIST. So on the left-hand side of this slide is the human kinome, which shows the complete set of protein kinases that are encoded in the human genome. So kinases basically act as key regulators of cell function and are a major target for anti-cancer drugs. So in these colorful circles on the left-hand side, the blue, the green, the orange, those represent targets that have approved drugs to target them. On the right-hand side, you see the targets of the kinome of the 5 drugs that are approved to treat GIST. The yellow circle that on top of imatinib, sunitinib, regorafenib, Abaprinib, and ripretinib denote KIT binding, and the red are just other kinases. So you can see that imatinib and Abaprinib are both fairly specific for KIT with some other targets, but sunitinib, regorafenib, and ripretinib have lots of other activity. And this accounts not only for their differences in efficacy, but also for the differences in their side effect profiles. So let's first talk about sunitinib, which was FDA approved in 2006 based upon this study. So this study enrolled a little over 300 people and randomized them. 2/3 of them got sunitinib and 1/3 of them received placebo. And in this study, everyone got the 50 milligram, 4 weeks on, 2 weeks off, but 37.5 milligrams daily is certainly another very acceptable way to dose this. And basically in this study, they found that the median progression-free survival was basically 4 times as long in the people that got sunitinib versus the people who had placebo. And this is denoted by this Kaplan-Meier curve that's sitting over here. The blue are people that had sunitinib and the red are the people who received placebo. And this figure basically demonstrates how much better the people that received sunitinib did. As many of you know, there are many side effects of this drug. Probably most people would say more than the side effects of imatinib that were previously described. Fatigue is present with this, as well as diarrhea and nausea. We do see some changes in the blood counts, particularly the red blood cell count. This drug can increase blood pressure, as well as cause a rash that's aptly named hand-foot syndrome that occurs on the palms of the hands and the soles of the feet. As well as some mouth sensitivity. So an efficacious drug, but slightly less tolerable, most people would say, than imatinib. 7 years later, this study was published regarding the efficacy of regorafenib in the 3rd-line setting. This study included about 200 people with GIST who had previously been treated with imatinib and sunitinib, and showed that on average, the median progression-free survival was about 5 months for people who got regorafenib versus only 1 month for people who received placebo. And so this also led to approval of this drug in the 3rd-line setting. Again, this drug has very similar side effects in terms of the hand-foot syndrome, the elevations in blood pressure, diarrhea, the mouth sensitivity, and fatigue. I would say loss of appetite and weight loss are probably something we see a tad bit more with this drug compared to sunitinib. So imatinib, sunitinib, and regorafenib have markedly improved GIST treatment, but drug resistance remains a problem. So this picture depicts the KIT and PDGFR alpha receptor tyrosine kinases that have previously already been described. What is new on this figure is on the far left and the far right, you can see that it says drug sensitivity, and underneath that there's imatinib, sunitinib, regorafenib, ripretinib, and Abaprinib. And underneath that, there are boxes that are associated with the various mutations that can occur, exon 9 and 11, 13, 14, 17, and then on this side in PDGFR alpha. The green denotes that the mutation, the drug is, mutation is sensitive to the drug. So here we see imatinib in these primary mutations works very well in both exon 9 and exon 11. But it doesn't work so well when we get down into these secondary mutations. So these secondary mutations are basically what confer resistance to imatinib. You can see that these can occur either in the ATP binding pocket or in the activation loop. And so these kind of account for the need for more drugs beyond just these three. And so this is where the next generation tyrosine kinase inhibitors of ripretinib and Abaprinib really came into existence with kind of their novel mechanisms of action and the thought that they would be more effective in sort of treating these secondary mutations. So this is ripretinib. So ripretinib is a novel agent. It is a type 2 switch control kinase inhibitor. So basically, as opposed to the other type 2 kinase inhibitors, imatinib, sunitinib, and regorafenib, this drug can bind both to the switch pocket and the activation switch and kind of lock this kinase in an inactive state. So it can actually bind when this receptor is in an active state, which is something the prior 3 drugs cannot do. This drug is also able to broadly inhibit both KIT and PDGFR alpha kinase signaling. And so this is what, and so this drug is now approved for advanced GIST treatment as long as the person has had 3 kinase inhibitors, one of which needs to be imatinib. So the efficacy of this drug was first evaluated in the Invictus study. So this was a randomized, double-blind, placebo-controlled phase 3 trial, and it compared ripretinib at 150 milligrams daily to placebo. This is, again, what we call 2-to-1 randomization, meaning twice as many people received the drug as received placebo. If there was progression of the GIST, people who were on daily dosing could increase to twice a day, and people who were receiving placebo could at first receive a drug, and then if they had further progression, could receive the drug twice daily. The primary endpoint of this study was also progression-free survival, tends to be the most common endpoint for many sarcoma studies. And so these were the results of this study. So this is another Kaplan-Meier curve looking at median progression-free survival. The ripretinib results are in blue and the placebo in red. The fact that these curves are very far apart often suggests that there's some sort of difference. And in fact, there was. The median progression-free survival for ripretinib was a little over 6 months, and for placebo, it was only 1 month. There were also differences in response rate, so almost 10% for people who received ripretinib and 0 for placebo. The median duration of response, or how long that response lasted, has still not yet been reached. The time to response was on average about 2 months, and then time to progression was a little over 6 months in people on ripretinib versus just 1 month in placebo. And the overall survival, although the study has some funny statistical quirks, so you can't technically say it improved survival. Numerically, the survival was markedly different between the 2 groups as well. So the side effects of ripretinib, we do see more hair loss with this compared to the other tyrosine kinase inhibitors. Again, fatigue and nausea, as well as muscle aches, diarrhea, and that rash on hands and feet once again. So because of its success in the 4th line setting, ripretinib was then evaluated in the 2nd line setting. So this is the Intrigue study. So a randomized open label phase 3 study where people received either ripretinib 150 milligrams daily versus sunitinib at the 50 milligram daily dosing. And unfortunately, the preliminary results from this study demonstrate there's no improvement in the median progression-free survival between the two groups. So although Ripretinib looks incredibly promising in the fourth line setting, it failed to meet its primary endpoint in the second line setting, and therefore did not overtake Sunitinib as kind of the new standard of care in the treatment of second line GIST, which we all thought it might, but unfortunately when this study was announced, the results were announced last November, it was no better, unfortunately. So then the last drug I'll talk about today is Abaprinib. So Abaprinib is a type 1 kinase inhibitor. It is denoted here in this picture. It is this yellow molecule sitting kind of right here. And it is approved for GIST that harbor the PDGFR alpha exon 18 mutation, including the D842V that was previously mentioned, and that's resistant to Imatinib. So unlike the TKIs that I've previously discussed, this one can bind to a kinase when it's in what we call the active conformation. So all the Imatinib, Sunitinib, Regorafenib, they all need to bind when it's in an inactive state. It's active in KIT and PDGFR alpha, and it is, let's see, this is the ATP, or this is the activation loop that's covered here in purple, and it's kind of in an open conformation. So this picture, although I thought it was kind of cool, but it's trying to show you kind of the unique nature and binding properties of this drug compared to the other tyrosine kinase inhibitors. So Abaprinib was studied in the Navigator trial, which was an open label 2-part dose escalation and then dose expansion study. It enrolled patients with unresectable GIST that had progression after Imatinib and also one other TKI, or those who had a PDGFR alpha D842V mutation in their tumor. And so 23 patients with the PDGFR alpha mutant GIST were enrolled. In the dose expansion, there were 3 cohorts, including one for the D842V mutant GIST patients. And so collectively, 56 people with this mutation in their GIST were enrolled. When they analyzed the results of this, it was pretty profound. So this is a waterfall plot, which shows the degree of tumor response when a person is receiving Abaprinib. So starting at the top, this line that's labeled PD means progressive disease, SD is stable disease, PR is partial response, and CR is complete response. And so basically, if these lines are going down from this SD, it means that there was some shrinkage. Now in the medical clinical trial world, I have to get to a certain percentage of shrinkage to surpass this PR line. But this is really quite a remarkable waterfall plot to see that most people on this study had their tumor shrink with this drug. So the overall response rate was 91%, including 13% of people who had a complete response to the drug. On average, the time for the tumors to respond to the drug was about 2 months. And the response lasted on, the median was a little over 2 years. So this was really revolutionary for a type of GIST that had no standard treatment prior to this. More results from this study showed that the 1-year duration of response was almost 75%, and the 1-year progression-free survival, 83%, and the 1-year overall survival of 91%. So again, just really quite remarkable data. And this is what led to the approval of Abaprinib for D842V mutant GIST. Like all drugs, it had some side effects, nausea, fatigue, low red blood cells. But in particular, the events that were a little bit unusual with this drug was that it caused more memory problems and confusion than we have seen with other TKIs. So this was a little bit unusual and actually did cause several people on this study to discontinue the agent, and something that we certainly see clinically as well, and something that's currently being studied to try to understand better why this occurs with this drug. Because it worked so well in the D842V patients, the thought was, well, maybe it will work well in advanced GIST all comers. So patients with GIST who had been previously treated with Imatinib and then either 1 or 2 TKIs were randomized between Abaprinib and Regorafenib. If you were on the Regorafenib arm and the GIST tumor progressed, you were allowed to cross over to Abaprinib. And the primary endpoint, again, was progression-free survival. So these are 4 Kaplan-Meier graphs from this study. So on the top left, you have all the people that enrolled in the study. And when you look at the red line, which is regorafenib, and the blue line, which is Abaprinib on the top left, you can see that they're pretty close to each other. And what that looks like statistically, numerically, is that there was really no difference in how the people did between those 2 groups. Similarly, in both the bottom left and the top right, which represent 3rd and 4th line treatment, there was really no difference in outcomes either. The only time that Abaprinib and regorafenib looked different was with regards to the D842V mutant GIST population. So there were 7 people in the Abaprinib arm and 6 in the regorafenib arm. And the Abaprinib patients seem to do a lot better. But this was unsurprising given that the drug is already approved for the treatment of this population, and we know that it works particularly well there. So unfortunately, this was a negative study, and Abaprinib did not pick up an indication for later lines of therapy in GIST. So this is just to summarize kind of recommendations for how to treat metastatic GIST. The first line is generally Imatinib, but it can be Abaprinib if it's a D842V mutant GIST. Second line, Sunitinib. Third line, Regorafenib, and 4th line, Ripretinib. However, at every phase of this process, consideration of a clinical trial can be reasonable depending on what's in reach for the patient. So this is a list of some of the ongoing clinical trials for people living with GIST. The first 2 drugs on this chart are temozolomide, which is a chemotherapy agent, and then rogoratinib, which is an FGFR inhibitor. Those are currently both being studied in very specific type of GIST that Dr. Kitty actually mentioned earlier, SDH deficient or mutant GIST. So very niche population, but very important to study, as there has not been huge advances, unfortunately, in some of these rarer mutations. The next 4 or 5 studies on this chart are basically looking at novel tyrosine kinase inhibitors such as CGT9486 or THE630, and then trying to add things like ripretinib and sunitinib. So if they both work well independently, could they work well together? There are a few heat shock proteins on here, so HQP1351 and pimitisfib. That's just kind of a different mechanism trying to go after some of these kinases and see if some of those downstream effects could be targeted. And then the last 2 options on here both incorporate some sort of immunotherapy. So immunotherapy is basically trying to take advantage of your body's own immune system and use it to treat cancer. And this strategy has proved very successful in numerous malignancies, but is still unfortunately very much investigational and just still waiting to figure out how we might be able to make that work. That's all I have. And I think I'm happy to take any questions. We can look at the chat and see.
Yeah.
I don't know how many there might have been.
Question.
Oh, yes.
Yeah, so I have a question. So, so typically you can get progression while on imatinib, and usually that's caused by a secondary mutation like exon 13 or 14. So what do you know what the cause is for progression while you're on like the second line medicine? Is it like even another secondary mutation, or do they know what's going on in those cases?
Yeah, I would say that generally speaking, it is probably another mutation within another domain, another part of the whatever, downstream, another kinase, another exon mutation. So it would be, the ideal would be is if you could sequence tumors every time a person started a study and every time there was progression on a drug, because then you'd have a really rich repository to analyze in terms of what is actually going on at the tumor level.
And I think the other problem is that you can have the GIST can have more than one secondary resistance mutation even at the same time. They kind of have their own little kind of pop-ups of different things. And so your second line treatment may be treating a portion of the GIST that has a sensitive mutation and not the other portion of the GIST. So it's incredibly complex.
Yeah, so that's where combination drugs would be very beneficial. And that's why I know a lot of the new trials are using those. So
Yep.
Okay, thank you.
Yeah, absolutely. And I think someone earlier in the chat had asked a question about kind of ctDNA and sort of how that's used for people with GIST. And, I think it's a really great question and definitely an area of active research. There are lots of people, that are checking ctDNA on patients and trying to interpret it. And I think it's a good thing to get data on, because I think it potentially would, it would be great if we could do blood tests on everybody instead of poking tumors repeatedly and trying to get samples. I think it's probably not quite ready for prime time, but certainly an excellent research tool. I don't know, Dr. Kitty, do you have other thoughts on that?
Yeah, it's still a sensitivity issue. So you have to have a pretty large disease burden for it to shed enough to actually be able to detect it. And there are, again, it's another thing that there are slightly different differences in practice. It was part of an advisory board, and the majority of us actually do not routinely check ctDNA. We just don't know how to act on it yet. It would be, we're ready for it. So we'll keep doing the research. I think there's an interesting one, the one about the KIT and PDGFR mutations. I think in general, they do not coexist. So they're considered exclusive of each other, the KIT and the PDGFR. There have been reports of GIST that will have like a KIT and a BRAF though, but we would treat it as the KIT mutation.
Yeah, that is a good question. I'm trying to go through the chat and see. All right, I think we've answered. I think you answered the neoadjuvant question.
I just received one directly.
Oh, good, wonderful.
What is the mass shown possible necrosis? Would a EUS biopsy be done first to confer GIST?
I think the question is asking if you got just purely necrosis on a biopsy, would you rebiopsy to confirm the diagnosis of GIST?
That's correct.
Okay. Yeah, I think in general, we like to have enough tumor tissue to make a diagnosis before acting on it. So I think, if possible and safe, I think we would try to biopsy again to try to make sure we knew what it was, what the tumor was. I guess the exception would be, if it was an urgent situation and the tumor was bleeding or ruptured and needed to be resected. I guess potentially that could happen.
There's a question about how many patients Vanderbilt treats. So we see probably about 50 new patients a year. So that's going to be a combination of just surgery plus treatment, patients with metastatic disease. And we have about 450 active patients currently.
You're talking about just GIST patients, right?
Just.
Okay.
Yeah.
Okay. I was like, those are very low.
Yeah.
Okay. Yes. Sorry, I didn't see the question, but yes, relative to our GIST practice.
I want to break in. Hey, Dr. Davis.
Hi. How are you?
Oh, good. I love
I'm
seeing
glad you're
everybody without masks.
Good to see you.
I've got the exon 9 mutation, and as far as I know, my first small bowel resection, it got spilt inside of me, and I'm dealing with a spill. So I don't know if anybody else on here is dealing with any of that, but I've actually got a GIST tumor on my outer belly that got pulled out in the first surgery. And I'm curious as to radiation and the new proton therapies that are coming out. Is there anybody on here that'll talk about that or knows anything if it does work on potentially to kill the tumors? That's my question.
And I think it's a great question. We use radiation and protons for lots of different types of cancers. I would say that full disclosure, since I know where your abdominal wall tumor is and your other tumor, I think probably radiation has not been our favorite strategy just in general with GIST. If we can, it's not that we never use it, but if we can use one of our drugs, or if we can do, a surgery or metastectomy or even ablation or some of these other techniques, that's generally where we've kind of gone. I don't know all of the data though in protons in GIST. And unfortunately, I do not think one of our radiation oncology colleagues is on the call today.
That's because we use so little radiation.
We do. I'm
it's
sorry.
just not considered super radiation sensitive.
Yeah.
Okay. I do have a question. What determines whether your GIST is hereditary or not?
Yeah, great questions. So typically when we're meeting a patient, we ask about things like family history and other medical problems. And so if there were, indications that that's potentially, there could be a syndrome going on or an underlying genetic syndrome, then we would usually have you go to our genetic counselors and they could do testing. And that blood testing is able to distinguish whether that mutation occurs in your normal cells. And so that's what makes it a hereditary syndrome, is if you're born with it and that mutation exists in your normal cells. So that's sort of, patients may not know we're doing that and thinking about those things when we're meeting somebody, but yeah.
Okay, thank you.
Does that answer that?
Yes, because I have history in my family for some form of stomach cancer, but it was never diagnosed as GIST.
Right.
So I want to know for future family members if this is something that's hereditary, but they've told me thus far it's not. So, okay. Thanks.
Yeah. All right. It's a great set of questions, great discussion. I think we're going to move to our next speaker, who is Erin Taylor, who is a clinical dietitian here at the Vanderbilt Ingram Cancer Center and who is essential in the care of many of our patients with GIST. So Erin, I think I saw you on here.
Yes, I am.
Wonderful. Thank you for coming today.
All right. Okay, there goes presenter mode, okay. So my name is Erin Taylor. I am the dietitian here at Vanderbilt, and I'm gonna speak a little bit more about the importance of nutrition during treatment. But first, I just wanted to talk a little bit about the dietitian's role throughout your treatment course. Some of the few things that we might do would be assess current dietary intake and potential for any deficiencies. We can provide medical nutrition therapy. And this is the prevention and diagnosis of malnutrition, and also improving quality of life through symptom management and nutrition-related symptom management. And we can provide targeted and individualized goals to make it work for you and for what you might need. And just in general, malnutrition is estimated to occur in up to 80% of cancer patients at some point during or after treatment. And there are a few reasons why cancer patients are more likely to be malnourished, but a few of the reasons that I'm going to touch upon today would be an increased demand for calories and protein, and also just multiple barriers that affect intake. And when I mention barriers, we're talking about things like early satiety or feeling full very quickly, poor appetite, nausea, vomiting, constipation, diarrhea, fatigue, which we've heard about before, taste and smell changes, which I'm actually seeing more often just with post-COVID related symptoms that are also affecting individuals' treatment courses. Any type of post-operative diet restrictions or vitamin deficiencies. And the reason why we're so focused on malnutrition and we want to prevent it is because it is associated with poor treatment outcomes, lower quality of life, decreased tolerance to different treatments, and increased hospital length of stays. But the good news is that working with the dietitian and working on your nutrition is associated with the improved treatment tolerance, reduces in treatment interruptions. It can prevent the decreases in body weight and specifically muscle mass loss, improves quality of life, decreases hospitalizations and the length of stays, and potentially could impact survival. And I just wanted to reiterate that multiple sessions are key in helping with the prevention of malnutrition and improving quality of life, because things can change throughout your treatment course. So it's been estimated that about 8 to 9 sessions with a dietitian is what can be most beneficial. And then I just wanted to touch a little bit on some of the most common symptoms that I might work with some GIST patients on. So the first one is early satiety, poor appetite. Some of our nutrition interventions are pretty similar here. But the number one thing that we'll talk about a lot are small frequent meals. And this is one of the more difficult things to focus on, because if you're used to eating a couple meals per day, making an overhaul of eating 5 to 6 per day is a huge behavior change. So I always recommend to start out small. If you're a 1 or 2 type a day meal person, let's just work towards 3, and scheduling out those times and just making an attempt to try to eat at those times. We also want to maximize when appetite is best, whether that be in the morning or the evening, and make sure that we are increasing the nutrient density of those foods. And when I say nutrient density, we're talking about higher calorie, higher protein foods. This would be things like a full fat Greek yogurt, avocados, peanut butter, almond butters. And another nutrient dense food would be an oral nutrition supplement like Boost or Ensure. And we also want to avoid liquids at meal times, just to make sure that we're filling up on the nutrients at mealtime and not necessarily on water at mealtime. Another nutrition-related symptom that I see pretty often, and we've touched on already, is fatigue. And this may be fatigue with preparing meals or just fatigue with the actual act of eating. So again, smaller, more frequent meals is a big recommendation. Making sure that if you are tiring out quickly when you're eating more frequently throughout the day. I also recommend batch cooking, just doubling the recipe if you are able to have a few days a week when you can cook something. These can be kept in the fridge, or I also recommend just keeping them in the freezer so that over time you'll have more meals on hand and you're eating different things and you're not just kind of eating off the same meal each week. I also get asked pretty often if frozen foods are okay, and they're absolutely fine to do. They can be great to just pop in the microwave and can still provide good sources of calories and protein. If you're having difficulty even maybe getting out of bed or just sleeping in a little bit later, keeping non-perishable snacks at bedside is great. So think nuts, fruits like bananas and clementines, or any type of oral nutrition supplements can be kept by the bedside if, as long as they're not opened. Again, if the actual act of eating is fatiguing you, we talk about soft, easy to chew foods. So you're having less effort when you're eating. And then oral nutrition supplements as well are easy to chew, they're non-perishable, and can be a great addition to your day-to-day. For nausea and vomiting, small frequent meals, once again, it's a little bit easier to digest. It's not hanging around in your stomach for quite as long and won't contribute to nausea. You might have also heard about focusing on bland or starchy foods, making sure that there's not any extreme odors or spices with the meals. Making sure that foods are cold or room temperature can, again, decrease the odor of the food, and also avoiding highly seasoned foods because they're a little bit more potent or pungent. High fat foods can also increase nausea. And when I say high fat, we're talking about like greasy burgers can sometimes not be the easiest thing on our stomachs. Avoiding food preparation areas. So if you are able to have someone else prepare your meals for you, avoiding that area while it's cooking so you're not smelling the food before you're attempting to eat it can be helpful, especially if you're sensitive to those smells. And the last one that I always like to point out is avoiding unnecessary vitamin supplementation, especially big multivitamins, if they're not needed in your day-to-day, can cause an increase in nausea. So always chat with any of your providers or a dietitian to see if maybe there are some vitamins that aren't necessary to take. And just a few things with post-operatively nutrition. It can definitely vary depending on the type of surgery that you had. But we're once again recommending small frequent meals. We want to kind of test the tolerance to a few foods because we don't want to impose any food restrictions that are unnecessary. We want to make sure you're getting protein and complex carbohydrates to really improve your status post-operatively. Separating your food and liquids, filling up on those nutrient-dense foods and not water at mealtime, and chewing your foods 20 to 30 times per bite to improve digestion. So the last thing that I have here is just a little smoothie recipe that I wanted to walk through that can be pretty customizable just depending on how you're feeling or what symptoms you might be experiencing. So this is meant to be very soothing. It's meant to be a smoothie that's helpful if you are experiencing some nausea. Watermelon, cantaloupe, and honeydew are all types of melons that are very mild. They're also low acidity. So if you are experiencing any type of acid reflux, they would be good fruits to consume for that. We have a really nutrient-dense food of whole Greek yogurt in there, another great source of protein. And in the smoothie, I'd also recommend some type of a protein powder just to increase your protein in the smoothie itself. And it can be whichever one you prefer. Half of a cup of almond milk or any type of milk you prefer. I just chose almond milk so that you've got a little bit of a vanilla flavor. And lastly, adding about a tablespoon of avocado oil to have a good source of calories and a healthy source of fats. So just like any smoothie, you can blend it all up. You can add sweetness as desired if you'd prefer to be a little sweeter. Honey goes really well with this. If you prefer thinner smoothies, you can always add more almond milk or water. If you want it to be a little thicker, using frozen fruits instead of fresh fruits will make it thicker. And then if you do want this to be a little bit gentler on your stomach, sometimes mint can be helpful, but only if you're not experiencing any symptoms of acid reflux, because that can be a trigger for some individuals. And then overall, we have almost 500 calories for this smoothie and about 26 grams of protein. So just to summarize, our main goal is to manage any nutrition-related symptoms and to make sure that we're preventing malnutrition to help you throughout all course of your treatment. There's no specific food or supplement that I would recommend, but rather a pattern of your intake that's going to be the helpful magic bullet throughout treatment. All right, and I'm ready for questions as well.
Thanks, Erin. I love the way you phrase that. There's not necessarily one food or drink, but it really is a pattern. I think that's a great way to think about nutrition. Anyone have any burning questions for Erin? Or if anyone needs to think for a few minutes, maybe we'll move on to Carrie and then come back and have a wrap up and see if more questions arise. All right, so Carrie Tomlinson is our next speaker. She is a physical therapist here at Vanderbilt, working at the Diani Center. So Carrie, take it away.
Great, thank you. All right, so as Dr. Davis said, my name's Carrie. I'm going to be talking to you guys about physical activity during your cancer treatment. Oh, if my slides will advance, I will. All right, my computer's been doing this all day. We're going to go without slides, so I will be able to see your faces. Not quite as fun, but I can definitely cover everything. So first of all, there's not a whole lot of research out there about exercise specifically related to GIST or sarcomas in general. The CDC, so the Center for Disease Control, as well as the ACSM, which is the American College of Sports Medicine, recommends that all Americans get more activity than we do. In 2018, they released a statement that says all Americans should aim for 150 minutes of aerobic exercise a week. And you can break this up into 5 30 minutes to 75 minutes, 15, 10 minutes, pretty much however you want to break that up. And then in addition to that, you should get twice a week of strength training. And after they released that statement, they did some studies and came in October of 2019 and specifically looked at patients with cancer. They really looked at patients who had cancer that kind of fall into those big buckets of cancer that get lots of money for research. So breast cancer, colon cancer, and additional others. And what they found is if you will exercise while you're going through cancer treatment, you can potentially increase your survival rate, but more importantly, you can address some of those side effects of cancer treatment, whether it's cancer-related fatigue or anxiety and depression. Really, again, so this study was looking at 7 specifics. None of those happen to be sarcomas, but we can really correlate between the two. So how do you get that movement? How do you get your cardiovascular exercise? I think first and foremost, as a physical therapist, is a little bit is so much better than none. If you can do 5 minutes of exercise today, that is 5 more minutes than you would have done. And the nice thing about the cardiovascular exercise, it can totally be what you enjoy. So it can be taking a dog for a walk. It can be walking outside with your grandkids. It can be dancing with your significant other. So it can be something that is fun, as well as it could be on a bike or a treadmill or anything along that lines, just moving for some form of movement. And then the other nice thing about that is what I tell all of my patients that are undergoing cancer treatment, you have no control over what's going on in your life. You can't control that you were diagnosed with cancer. You certainly can't control what medications you're using. You can't control that the doctor says, hey, we have to have another biopsy, but you can control today if you do some form of physical activity. So I can control this morning that I'm gonna do 5 sit-to-stands today and get 5 minutes. And so a way of just slowly increasing those cardiovascular to get to that big lofty goal of 150 minutes. The other thing that the ACSM and the CDC recommend are those resistance training. So twice a week of some form of strength training, whether this is doing a bicep curl with a soup can, or whether this is doing a push up against the wall. Anything that gets your muscles moving, it can be standing up, it can be a squat, it can be anything that goes over multiple joints is what we're going for. So a lunge is going to be better than getting on a machine and kicking your legs out. So we want something that you can do at home, you can do in the hospital, or you can do on your way to treatment. One of the studies that has come out recently, it was just released last year in October. And again, it was looking at breast and colon cancer specifically. But this study found that patients that are exercising during treatment for breast and colon cancer actually had a better survival rate than what their activity was before they were diagnosed with cancer. And what I like about this and what I tell my patients is, you know what, if you did exercise before, I think that is wonderful and that is great. But if you can start today doing some form of exercise, the benefits on survival improve. Again, specifically for our breast and colon cancer, but for all our patients with cancer, we know for a fact that exercise can decrease your anxiety and depression, can decrease your cancer-related fatigue, and can improve your function and quality. As to the why, so what is the science behind this? All we have from the ACSM is we have no idea. We have a lot of great theories as to what's going on, but as to why does exercise help with cancer, they really don't know. The great theories are, we know that exercise, we know that movements will decrease your inflammation. We know that exercise and physical activity can decrease your insulin level as well as your hormones. And the thought process is, okay, for decreasing inflammation, that has a direct correlation that we know and science has studied to decrease pain and improve mood. So what we're really trying to get at is move, whether it's 2 minutes and 5 sit-to-stands or whether it's going out for a walk with your friends, your family members. If you get anything from my rambling without slides, because I couldn't control that it broke today, please hear that controlling and trying to go for some form of movement every day is what we're aiming for and shooting for. Specifically at Vanderbilt, we have several things that we offer to our patients. So if you happen to be one of Dr. Davis's patients, she has all that. But again, we're just trying to get our folks to move, to address and control as much as they can. So I'm so sorry my slides didn't work, but that is the gist of Get Up and Move. And I went really fast because it looks like we're running out of time. And I think there are a lot of more questions for you, Dr. Davis.
Carrie, that was fantastic. I don't think you needed slides. I think it went perfectly well, just as it was. And I'm so thankful that you're here and for all the efforts that you have for our patients. And I don't know if there's any more questions anyone has for Carrie, Erin, myself, Dr. Kitty. I think Dr. Mcgee may still be on. I think Dr. Prieto-Granada had to drop off to go to another meeting. But we're happy to take any last questions before we turn it back to Diana and Laura.
Well, I just want to say thank you to our new friends at Vanderbilt. We are so excited that we were able to bring this to you today, and such new slides, some new slides to me anyway, that I haven't seen in typical presentations. And I can see the passion that you all have in your presentation. And we at the LifeRaf group look forward to working with you in the future. I am especially grateful that you brought both nutrition and exercise to the forefront here, because we get questions all the time from our community, and many of our patients, as you know, do have difficulty eating and a lot of stomach issues. So we're glad that you brought that out. We're going to make sure that we have that at our event in July, our LifeFest event. And if you're all members of the LifeRaf group, you've been getting a lot of information about that. I encourage you to join. Again, thank you. Closing out, beginning your weekend, closing out this program, we had 45 people attend on a Friday afternoon, and that says something about our presenters. So thank you so much. Enjoy your weekend, everybody, and stay safe.